Hello and welcome to #OurDocTalk at NorthBay Healthcare. This is a chance for our doctors to reach out to the community and share information on various health topics. Today, our guest is Dr. Jessica Power. She is a hematologist and oncologist at NorthBay Healthcare's Cancer Center. She's been with us a little over a year?
I started in March, so a little over 6 months.
Okay. So she joined us, coming to us from David Grant Medical Center at Travis Air Force Base after having served in the U.S. Air Force. She's a graduate of the University of Virginia and earned her doctorate in medicine from the Virginia Commonwealth University Medical College of Virginia campus.
Yes.
So welcome, Dr. Powers, and
Thanks.
thank you for taking the time to do this. Answer questions on all things breast cancer. October is Breast Cancer Awareness Month, and today's chat will focus on some of the basics about breast cancer. Then this evening at 6 p.m. we continue our community outreach on the subject with a Doc Talk live event called If Only Your Genes Could Talk, featuring a cancer survivor as well as oncoplastic surgeon Dr. Jason Marengo and North Bay's genetic counselor Karen Vikstrom. That will be at our Green Valley Administration Center at 4500 Business Center Drive in Fairfield. So again, welcome, Dr. Powers.
Thank you. I'm glad to be here.
Now, 1 in 8 women will be diagnosed with breast cancer in their lifetime in the United States. So let's start out our chat with some basics.
Okay.
What is breast cancer and how does it develop? Why is it so prevalent and dangerous?
Breast cancer, it's a very heterogeneous group of diseases, but the term breast cancer includes all the different subtypes, so I'll keep it very general when I'm describing it. And cancer in any part of the body, and specifically in this chat with breast cancer, is when there is a proliferation of an abnormal cancer cell in the breast, in this case, that grows into a tumor. And we don't know all of the different risk factors or all the different things that can cause breast cancer, but we do know certain risk factors, which I think we'll get into a little bit later in the talk. But basically, it's an abnormal collection of cells that grows into a tumor, and the reason it can be harmful or deadly is because it can get into the bloodstream or the lymphatic system and spread to other parts of the body. And that's where it can become metastatic or stage 4, and that's where it can become the most dangerous and the most deadly form of breast cancer.
Can you explain a little bit about the most common risk factors?
Sure. So there are some genetic risk factors, but most women who have breast cancer don't have a genetic risk. The biggest risk factor is being a woman, although men can get breast cancer. It's rare, but it's possible. Increased estrogen exposure. So that means women who take estrogen hormones, often at the time of going through menopause to relieve some of the menopausal symptoms, has been shown to be a risk factor. Alcohol use is a risk factor. Obesity is a risk factor because having extra body fat increases estrogen levels, and that's been shown to increase breast cancer risk. Additionally, people who have had any radiation to their chest wall, we see that in patients who are survivors of specifically lymphomas in childhood who've had radiation to their chest wall, and that turns out to be a risk factor as well. And there are some other environmental exposures and risk factors that haven't been very clearly defined, but the things that I mentioned are the most common, most pervasive, and the most sometimes preventable risk factors.
Okay. So is it preventable?
I think that there's a lot of things that an individual can do to lower their risk, and those are the lifestyle factors. So avoiding alcohol is a big one. Also, and if you are a alcohol drinker, taking a folic acid supplement has been shown in a few different studies to reduce the risk. So I think that if you do drink alcohol, it's important to take folic acid to kind of counteract that risk. Other things are healthy lifestyle choices, healthy low-fat diets that help maintain healthy weight with a BMI less than 25. 20 to 25 is optimal on your body mass index. Additionally, not taking exogenous hormones, not taking estrogen or progesterone supplements as you're going through menopause. Exercise, maintaining a healthy weight. and screening. Good screening is not necessarily preventative, but it does help us with very early detection, which has been shown to improve survival and save lives.
So what are some of the most common signs and symptoms of breast cancer?
For some women, for some people that get breast cancer, they don't have any signs or symptoms, and we pick it up on a routine mammogram. It could also present very aggressively with a very fast-growing lump or mass in the breast, and that could cause some skin changes or some nipple discharge. Sometimes it just presents just with a very tiny little lump that a woman notices and kind of watches it for a while, and then once we get that identified by the doctor or by the healthcare provider or the mammogram, sometimes the patient will say that it's been there a while and maybe didn't grow very fast, so they weren't worried. Other signs would be skin dimpling. If you look at your breasts in the mirror and you notice that there's a change in the contour of the breast, that could indicate that there's an underlying mass that is causing retraction of the skin. Nipple inversion is another common symptom or sign, and also if there are any enlarged lymph nodes under the armpits, that also can be a sign of breast cancer that may have spread to the lymph nodes. Skin changes on the breast, if there's a red rash or something that just doesn't seem normal, it's always best just to get it checked out, and that's what we recommend, is just being aware of your body, doing self-breast exams, monitoring for any changes, and then alerting your healthcare provider if you find anything that's concerning.
So you mentioned lymph nodes. Could you do a little explainer for those people who don't know what you're talking about?
We all have lymph nodes throughout our body, and those are normal, and those are part of our immune system, and they help remove things that shouldn't be there during times of infection, and they help bring in the things that need to be there, like white blood cells and things that are important. Lymph nodes can get enlarged if there's any inflammation in the breast, and the lymph nodes that drain the breast tissue are under the armpits. So if you find a lump under your arm, that could be it could be a lymph node and probably should be evaluated.
Okay. Why is a mammogram so important, and how often are we supposed to have them?
I recommend all women starting at age 40 have a yearly mammogram, and there's been a lot of controversy about defining the exact screening, but as an oncologist, I see enough young women with breast cancer that I err on the side of very aggressive screening, and it should be done once a year. And the reason it's important is because sometimes the earliest change we see in the breast with breast cancer might be a tiny calcification or a tiny abnormality in the breast tissue that's not necessarily palpable. You can't really feel it, but maybe we could see something on a mammogram that might allow us to identify a pre-invasive breast cancer or a very early breast cancer. And if we can treat those at the earliest possible stage and identify them at the earliest possible stage, we can prevent the more advanced types of breast cancer that tend to have the higher risk associated with them and that might need more treatment. So not only does early detection save lives, but another way to think of it is if we detect it early, if you have a precancerous lesion, we can remove it just with surgery, potentially some radiation, and then avoid the need for more aggressive therapies like chemotherapy. It's typically the more advanced types of breast cancer that require chemotherapy. So if we can identify and treat early, we can avoid some of the toxicity or some of the side effects from treatment.
So how do you know if a lump is something that needs to be checked out right away? And when should you worry about a lump and what you should do if you find one?
Absolutely, that's a great question, and that's a very common question. Any lump in the breast should be evaluated immediately, and I say that because I would rather a patient come in and get checked out, and we reassure the patient, and we find out that it's nothing to worry about, than to miss a cancer at its earliest stage. So I think if you find a lump in your breast, you should call your healthcare provider immediately and be in to be seen. And that the workup should include a physical exam at the very least. And if your provider also feels a lump, I think that a referral for potentially a mammogram or an ultrasound or both, or a referral here to the cancer center so that we can help work that up and help make an appropriate diagnosis and make sure that the appropriate workup has been done.
Now we have a question from one of our followers on Facebook. While taking Herceptin and oral tamoxifen, okay, only, will taking antioxidants like fruits and other supplements be in conflict with the Herceptin and the other drug treatments?
That's a great question, and not that we know of. During radiation, taking supplemental antioxidants, like in the form of extra vitamins, may lessen the impact of the radiation. But as far as with Herceptin and tamoxifen, taking antioxidant-rich foods is preferred and is really good, just as a healthy lifestyle choice. I tend to recommend against supplemental vitamins and supplements and those kind of things during active treatment. But if you're eating a diet that's rich in those antioxidants and eating a lot of healthy fats like in almonds or walnuts, I think that's been shown to be very beneficial. And as far as we know, there's no specific interaction with Herceptin or tamoxifen.
Great, thank you. Is breast cancer hereditary?
Well, that's a loaded question, Robin, but it does appear that there is a hereditary component, but it's not solely hereditary. And what that means is if you have a family history of breast cancer, you're at increased risk of breast cancer, but it's not a guarantee that you're going to get it. It's just an indication that your family may have a genetically influenced type of breast cancer. And if you have a significant family history of breast cancer, it would be reasonable to consider genetic testing, and that's something that Karen Vikstrom does for us here and does it very well. And the genetic testing has really come a long way, and I would recommend requesting a referral to see her if you're at all concerned about your family history and if you would like to consider genetic testing. Genetic testing can be is most often negative, but it might help us identify or screen you a little bit more closely if you do have an inherited risk of getting breast cancer.
Okay, we have another question from one of our followers. How often should women do self-breast exams, and when is the best time of the month for them to do that?
I think monthly self-breast exams are probably best if you can remember. And I think the best time if you're premenopausal is right after your menstrual cycle, because the breast tissue does get a little bit more tender and swollen right before your period starts, and that can mask a lump, and it might just be very tender and make it difficult to do a very thorough breast exam. And you should really pay attention to anything that changes. All breast tissue is lumpy and bumpy, and that's normal, but if you feel anything that's different or new, or if you see any visible changes in the appearance of your breast, those would be some reasons to notify your doctor or your healthcare provider for an evaluation.
All right, we were talking about hereditary and getting tested. Could you tell us what BRCA is? I think you say BRCA.
Yeah.
And who should be tested for it?
Okay. BRCA or BRCA is an inherited genetic mutation that has a very, very high risk of breast cancer. So high that we, if we identify a BRCA mutation, we recommend prophylactic or prophylactic just means removing, that we would remove the breasts prior to getting breast cancer, because the breast cancer risk is 70 to 80% in patients that do carry the BRCA mutation. If you're at a stage in life where you want to have children and breastfeed, or you'd like to delay breast removal, we just do very aggressive screening in patients who are diagnosed with the BRCA mutation. Again, it's very rare. Women who might consider BRCA testing are a very strong family history. So, like if several first-degree relatives have breast cancer at a young age, maybe a sister and a mom or two sisters, or if there's any male breast cancer in your family, or if there is ovarian cancer along with breast cancer, that's a red flag. If there's a lot of triple negative breast cancer, which we'll get to a little bit later in this talk, that also is a red flag. Early onset breast cancer in a patient who's premenopausal and gets an aggressive breast cancer, that's a warning sign. So there are very specific criteria of people we should look for the BRCA mutation in. But if you have a family history of any of the things I just mentioned, or if that rings a bell as being possibly true in your family, then it might warrant a discussion with your healthcare team to consider a referral to us so that we could talk more specifically about your individual case, to consider whether or not we should do genetic testing for the BRCA mutation.
Okay. We have another question from our followers. Some studies say to avoid sugar when you have cancer. Is fruit juicing not recommended? What are your thoughts? Also, what is your opinion on heavy carrot juicing, 12 carrots a day after chemo and during Herceptin?
I think that we all want to make lifestyle changes and choices that can minimize our risk of complications or of getting cancer. And the internet is a blessing and a curse. There's amazing information out there, but sometimes it's conflicting and overwhelming. There's not any clinical trial, solid science data that sugar feeds cancer, but that's a very common misconception. And my approach with my patients and what I recommend to folks in general is just everything in moderation. I don't tell patients to completely eliminate sugar from their diet. Now, natural sugars like you are getting from your fruit juicing is preferred over granulated sugar that you might add to bake a cake or something like that. But it's still okay in moderation. I think that just looking at the big picture, healthy, again, just back to healthy lifestyle, daily healthy diet with an occasional piece of cheesecake in there is totally fine. I just would say monitor your weight as a good indicator of your caloric intake, and maybe limit some of those extra sugars, and try to get your sugar from natural sources like fruits and vegetables. The question about carrot juicing, I think it's reasonable. There's a lot of vitamin A in there, and with Herceptin, there shouldn't be any interaction, and I think natural fruit and vegetable juicing is a great way to supplement and add vitamins and nutrients to your diet. And any plant-based food options have again and again shown to be superior to animal products as far as overall health and probably cancer risk.
Okay. Well, you mentioned it, social media and online information. We love that here at NorthBay, but there is a lot of bad information out there, so let's settle some things right now.
Sure.
Does breast size play a role in whether or not you get breast cancer?
No, but what it might do is make it difficult to detect on self-breast exam. If you're very large-breasted, you may not feel like a very deep lump. So I just use that as an example, because that's another little reminder to get your mammogram every year. Because if you can't feel, if you have a breast cancer that's very deep in the breast and you can't feel it because you have large breasts, then we probably would see it on a mammogram, and we might find it earlier than you might find it if you were just trying to feel.
Okay, how about wearing a bra all the time? Does that have any impact on whether you get breast cancer?
It doesn't appear to. There's never been any proven association between wearing a bra and breast cancer risk.
And how about benign cysts? Can a benign cyst become cancerous?
Typically not. A benign cyst is just a fluid-filled cyst, and it can feel like a lump on breast exam. And they can be very scary because they often happen in very young women. But we can tell the difference on mammogram and ultrasound, especially on ultrasound, between a fluid-filled cyst and a more concerning lesion. And those can be aspirated, which means that a needle can be inserted into the cyst with the ultrasound guidance to remove the fluid if we're concerned about the potential for that being cancer. And if it's just uncomfortable or if it's very sizable, those cysts can be removed. And but they don't, if there aren't any cancer cells in there, a cyst doesn't turn into breast cancer or doesn't increase the risk of breast cancer.
Okay, we have a question about hyperbaric. Is that beneficial to do after chemo? If yes, is it okay to do even when you're on Herceptin treatment?
I'm not aware of any data for hyperbaric therapy and breast cancer risk. What that would potentially do, and where we do use hyperbarics, is to improve oxygenation or blood flow. We use those in, oftentimes hyperbaric therapy is indicated for slowly healing wounds and things like that. But as far as reducing the risk of breast cancer recurrence or lowering the chance of getting breast cancer, there's not any science that I'm aware of that shows that that's beneficial.
All right, let's talk about some common treatment options.
Okay.
How is breast cancer treated? Is it always chemo and radiation or some combination? How's it work?
Well, breast cancer is a very broad group of diagnoses, and every single patient's treatment needs to be individualized with a multidisciplinary team. And what I mean by that, multidisciplinary would mean a surgeon, like Dr. Marengo, our breast surgeon. He's also a plastic surgeon, and a plastic surgeon should be involved in your care. A medical oncologist, such as myself or my colleagues, Dr. Long, Dr. Lopez, Dr. Vikstrom. Additionally, we need to include our radiation oncologist. Dr. Plow here with us sees all of our patients. And that multidisciplinary team needs to come up with the individual treatment plan for the individual patient, taking into account what the patient's goals of care are, taking into account how big the tumor is, where it's located. When you meet with your surgeon, they'll talk to you about a lumpectomy versus a mastectomy. A lumpectomy is where just the area of the breast that involves the cancer is removed. A mastectomy is removing the entire breast, and it's an individualized decision. It's based on patient preference, based on the size of the mass and what the cosmetic result might be if we do a lumpectomy and if we do a lumpectomy in a very large mass in a patient who has smaller breasts, then the cosmetic outcome would not be desirable. So sometimes in those cases we might recommend a mastectomy with reconstruction. So it's just very individualized. So that's the surgical part, which is an essential part of all breast cancer situations, unless it's a rare patient who presents with stage 4 metastatic disease, where the cancer has already spread outside of the breast at diagnosis, and that's very rare. So for most patients, breast surgery is a cornerstone of the treatment, and that's individualized and includes sampling of the lymph nodes in the axilla or under the arm, because that's the area that the cancer spreads first, and that's the area where we identify whether or not you have node positive or node negative breast cancer, is by biopsying those lymph nodes. So surgery is one cornerstone absolutely required for almost all breast cancers. Second thing is radiation. Radiation is often needed. Radiation is nearly universally recommended in patients that have a lumpectomy to reduce the risk of local recurrence. In a patient who has a mastectomy, there are certain reasons that we might offer post-mastectomy radiation, and that would be if the tumor is very large, greater than 5 centimeters, if there are positive lymph nodes. And again, all of these are individualized with your treatment team. We take into account other medical problems, other things that might make your treatment path a little bit more unique, and that might include just that if you have certain other medical conditions, or you're of an advanced age, or certain things that we consider for each individual patient to really individualize that treatment plan. And then comes the question of chemotherapy. Again, very individualized. It depends on many factors. It depends on the size of the tumor. It depends on the age of the patient. It depends on whether or not the lymph nodes are involved. It depends on the aggressiveness. We have a thing we look at called Ki-67, which tells us how rapidly those breast cancer cells are dividing. We consider that. We consider whether or not it's estrogen receptor positive or negative, whether or not it's progesterone receptor positive or negative, whether or not it's HER2/neu positive or negative. What else do we look at? Basically all of those factors together give us a recommendation, give us an idea of what might be best for that patient, and then we meet with the patient and talk about our recommended treatment plan. And we all meet together at a tumor board every other week to talk about all of our breast cancer patients and make sure that we're following the current international guidelines, and we all do here at NorthBay, and we all work together to collaborate and to offer the best treatment for the individual patient. So it's hard to say yes or no about chemotherapy just by looking at the chart or just by the first mammogram that might be abnormal. A lot of different factors come into play, and it really comes down to the biology of the tumor, which we're learning more and more about as researchers have developed different tests that might be prognostic as far as a patient's likelihood of benefit from chemotherapy. We have a test we send called Oncotype DX, and that gives us a recurrence score. We use that in certain subtypes of breast cancer to help us decide. So lots of different factors to consider. One other thing that we also take a look at is, like I mentioned, the patient's individual preference, of course. If a patient has estrogen receptor positive disease, that's estrogen receptor or progesterone receptor positive, but HER2/neu negative, we might opt to just use anti-estrogen therapy, which would be something like tamoxifen or Arimidex or Femara, or and those would be oral therapies that you might take once a day for 5 to 10 years. So we have many options. As time goes on, we are treating less and less women with chemotherapy for breast cancer, because we're able to better identify now who really needs it. I would say that most breast cancer patients I see do not need chemotherapy, because we're able to detect it early enough and treat it with surgery and potentially radiation and potentially anti-estrogen therapy, and avoid the toxicity of chemotherapy. However, there are still many women with breast cancer who need chemotherapy, and we offer all of the best treatments here, and we follow the national guidelines, which are consistently changing. So it's important to just really individualize a patient's treatment, and there are many factors that really play into that. And it's developed over the course of the workup and the evaluation of the breast mass, or the abnormal mammogram, and we kind of just collect information as we go, but it really comes down to what we find on that pathology specimen from either the biopsy or the surgery. Sometimes we give chemotherapy before surgery, and there are certain situations where we do that, and especially in HER2/neu positive breast cancer, that's one thing that we often do here now.
Could you explain a little bit about HER2? What is that, and what does it have to do with how a breast cancer is classified, and also explain staging?
Okay, so let's start with staging. So breast cancer is stage 0, stage 1, stage 2, stage 3, or stage 4. And stage 0 would be if someone has DCIS, or ductal carcinoma in situ. And that's where you have breast cancer cells that are lining the duct in the breast, but not percolating out into the stroma or into the surrounding tissue. DCIS has a very, very low risk of spread. 99% 10-year survival. DCIS is a pre-invasive type of breast cancer. So that's stage 0 breast cancer. Stage 1 might be a small lump without any lymph node involvement. It could be up to a couple centimeters. Stage 2 is typically a bigger mass, maybe some lymph nodes. And it goes on and on, all the way up to stage 4. Stage 3, stage 2 and stage 3 are the bigger locally advanced breast cancers, typically with lymph node involvement. Stage 4 is when the breast cancer is spread to another part of your body. So that doesn't mean the axillary lymph nodes per se, but it might mean that your breast cancer has spread to the bones, or to the lungs, or to the brain, or to the liver. And stage 4 breast cancer is treated differently than the other stages if it's diagnosed as stage 4. But so the staging really just gives us an idea of how advanced it is and how risky it is, and kind of helps guide treatment. The other question you asked me was about HER2/neu, and so HER2/neu is an intracellular protein that can be overexpressed in some breast cancer. It's the minority of breast cancer that overexpresses HER2/neu, but it does increase the proliferation rate. It increases how rapidly that cancer can grow, and it increases the aggressiveness. And the reason that's important, number one, for prognostic purposes, to know that it's a more aggressive subtype of breast cancer, but also to know that the good side of having HER2/neu positive breast cancer is now we have some amazing therapies developed, mostly by Genentech here locally, that are that target that HER2/neu protein and really improve survival. And one of the biggest advances in breast cancer treatment over the last decade has been the advancement in the treatment of HER2/neu positive breast cancer. So we're all very excited about these new agents we have, because it's not necessarily the drugs I'm talking about in particular are Herceptin, pertuzumab, and those particular drugs that really target that HER2/neu protein. Kadcyla is the other one. Those drugs are very specific to the HER2/neu overexpressing breast cancer cells, and those are very well tolerated in general, and have really made a remarkable improvement in the treatment and in the prognosis of women with HER2/neu positive breast cancer. So that is one of the markers that we look at when we do a biopsy, or when we do a removal of a tumor. because it really, when I was talking about the biology of the tumor defining the treatment plan, HER2/neu is huge, so is estrogen receptor and progesterone receptor positive.
Okay. We have a few more questions here from our followers. One is there any negative effect if the ER/PR score is low, but the patient still takes tamoxifen? I have a hard time with that word.
That's
Sorry.
Okay. If there's any positivity, 1% or more, we offer anti-estrogen therapy like tamoxifen or aromacin or Femara or Arimidex. And the reason is women with any positivity whatsoever do benefit. It's probably fair to say that tumors that have a higher ER positivity score, like 100%, probably have a greater benefit, but there's still benefit if the tumor expresses any estrogen receptor positivity or progesterone receptor positivity.
Okay. After chemo and double MX, what should a yearly checkup comprise of? Scans, blood tests?
So that's a good question, and I'm assuming that question is about a patient who has had breast cancer and now has had completed treatment with a bilateral mastectomy, and it sounds like some chemotherapy. The yearly exam would be meeting with your oncologist to talk about how you're doing and to report any new symptoms. What we're looking for in that situation is we're looking for any chest wall recurrence, so we should do an exam of your chest wall along the scars to see if there are any new lumps or bumps or skin changes at all. We should feel the axillary lymph nodes to examine the lymph nodes and see if there's been any interval growth of those lymph nodes. Additionally, the patient, are very important to tell us about anything that might be new. That might mean abdominal pain, abdominal bloating, cough, headaches, new bone pain. Any of those symptoms probably should be reported, because what we're really watching for in a patient who's had a bilateral mastectomy is recurrence of the breast cancer at another location. We're looking for, if it goes to the bone, for example, you may have pain at that area. If it goes to the lungs, you might have a cough or some problem with your breathing. So it's really be your own advocate and make sure to let us know. Don't wait for your yearly appointment if there's a change. Let us know. We do not do what's called surveillance scans for a woman who's had bilateral mastectomy. We don't do full-body CT scans because it hasn't been shown to impact survival in clinical trials. Additionally, every time you have a scan, you're exposed to some radiation, which can be cancer-causing. So we limit recommending or doing CT scans or PET scans for patients who where it's been shown clinically to make a positive impact. And in women who have had breast cancer, there's without symptoms, there's no role for routine scanning to monitor for breast cancer recurrence. In women who still have breast tissue, we do continue mammograms and ultrasounds and things like that for any palpable abnormalities. The palpable abnormalities is when we get the ultrasound. We still recommend yearly mammogram in women that have had breast cancer and have breast tissue remaining. But as far as lab tests or scans, it's not recommended in a patient who has completed therapy for breast cancer in the absence of new symptoms.
Okay, we have two more questions and then we're going to have to wrap up because we're already at the end of our time. But this person had chemotherapy and during the chemotherapy their period stopped, but their OB-GYN gave them medication to start it again. Is there any potential negative impact of that?
I think it depends. I think potentially, for example, if you have estrogen receptor positive breast cancer or progesterone receptor positive breast cancer, and if the medication that your gynecologist gave you to resume menses contains estrogen or progesterone, that could potentially be a negative thing. So it's debatable on if it's triple negative breast cancer, whether or not it's safe to take any hormonal therapies, but I would err on the side of recommending against any exogenous or any extra hormones.
Explain triple negative.
Okay, so triple negative. Triple negative is one of the most aggressive and rampant and most difficult to treat types of breast cancer. When I've talked today about estrogen receptors and progesterone receptors and HER2/neu, those are all things we look for on breast cancer cells or inside breast cancer cells, and those are targets for treatment. Triple negative is a breast cancer that doesn't overexpress any of those three things. There's no abundance of estrogen or progesterone receptors, and HER2/neu is not overexpressed. It tends to behave very aggressively. It tends to grow very rapidly and spread earlier than other types of breast cancer, and it tends to be more difficult to treat because all we really have is chemotherapy. We can't use the tamoxifen or Arimidex or any of the anti-estrogens, and we can't use Herceptin or any of the HER2/neu targeted therapies because the breast cancer cells don't respond to those treatments. So triple negative is a place where there's lots of ongoing research, and there's definitely hope for the future. But right now, chemotherapy is what we're left to treat those patients with, and we do the best we can. But it tends to be the most difficult and most aggressive subtype of breast cancer.
And our last question, one more question about BRCA, and what does that tell a doctor when they...
If somebody has a BRCA mutation, we just know that there's a very high risk of breast cancer, ovarian cancer. There's also an increased risk of many other cancers like melanoma and brain tumors and pancreatic cancer. So it's just it's a very high risk genetic mutation to have. And what's helpful about knowing is that we can do prophylactic surgeries. It's recommended, as I mentioned, to do prophylactic mastectomies, and it's recommended to do prophylactic removal of the ovaries in women who are finished having children because the risk of those cancers is so high. And in someone that has a known BRCA mutation, we tend to screen for other types of cancers and just follow them a little more closely than someone who does not have a BRCA mutation, and that's because of the increased risk of developing a cancer.
Okay, well, thank you very much for taking your time to do this today. Again, just a reminder to all of you out there in the Facebook world that tonight at 6 p.m. we continue our community outreach on the subject of breast cancer with a Doc Talk live event called If Only Your Genes Could Talk, featuring a cancer survivor as well as our oncoplastic surgeon, Dr. Jason Marengo, and NorthBay's genetic counselor, Karen Vikstrom. That's at our Green Valley Administration Center, 4500 Business Center Drive in Fairfield. So thank you again, Doctor.
Thank you. Thanks for listening in.